Hello, everyone. I'm American College of Radiology Director of Public Affairs, Sean Farley. Welcome to this ACR RBMA webinar. We will have three presentations tonight, followed by a question and answer session. First up, ACR Economics Commission Chair Dr. Ezekiel Silva will explain current clinical decision support requirements. Next up, Linda Wilgus, RBMA Federal Affairs Committee Chair, explores how the mandate impacts business managers and why your practice should work with referring providers now to get ready. And Mike Bull, IHE International Radiology Planning Committee Co-Chair and Chief Operations Officer of Radiology Group PCSC, outlines steps you can take to implement CDS in your practice and interact with CDS on a daily basis. After the presentations, we'll be joined during the Q&A session by Bob Cook, Vice President of the National Decision Support Company, which offers the Care Select Imaging ACR Select CDS platform. Now, before we get started, let's go over a few items to help you take part in tonight's event. By default, you joined the presentation using your computer speaker system to listen to the presenters. If you want to join over the telephone instead, just select telephone in the audio pane and the dial-in information will be displayed. You can also submit text questions to tonight's presenters by typing your questions into the questions pane on the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session. Also, tonight's webinar is being recorded. You will receive an email with a link to the recording over the next couple of days. Please answer the survey questions in that email so that we can improve these webinars by making sure that you get the information that you want and need. And with that, I would now like to introduce ACR Economics Commission Chair, Dr. Ezekiel Silva.
Thank you. And as Sean mentioned, so this is Zeke Silva. I'm the chair of the ACR's Commission on Economics. I'm a practicing diagnostic interventional radiologist with the South Texas Radiology Group in San Antonio, Texas. And I really appreciate this is our third webinar in this series. And just to restate what Sean said and what Sean implied, the goal of these webinars is for us to take a purposeful approach to implementation of what is a statute that was passed in 2014. And one important aspect of this webinar series is our listening to the feedback from the participants of the webinar. Some of this is through the questions that Sean mentioned through the web format. Some of it's feedback later. But what we want to do is respond to that. And some of the feedback we received going into this webinar was the following. One was that we do care about the rules and regulations, and that is going to be discussed by the other two panelists on this call, but that we, among the attendees, are looking for practical ideas, practical solutions for implementation of this program, number one. Number two, the feedback that we've received is, we're being asked a lot. We're being asked to put into place nationally and within our local domains and within our systems, a program that takes some effort. And the question is, where did that come from? How did that originate? So rather than me taking my time to go through the regulations as I did on the first two webinars, I'm going to leave that to my subsequent panelists. And what I'd like to do is I want to walk through relatively quickly, but objectively and factually, sort of the history of this program, sort of the AUC movement and the mandate itself. And I'm actually going to go back to the early 1990s. So when Bill Clinton ran for his first term, one of his important campaign promises and focus was on healthcare reform. So early in 1993, he created a task force. And to her credit, First Lady at the time, Hillary Clinton, was the chairperson of that task force. And as with payment policy, radiology is a fairly significant contributor to that. And there were discussions about radiology's role within the new healthcare reform system. And the question was raised is, where can radiology contribute positively and constructively to these ideas? Next slide, please. So in November of 1993, then chair of the ACR's Board of Chancellors, K.K. Wallace, and K.K. Wallace is from North Carolina. He goes before the House Ways and Means Committee, and the person on the left of the screen, that's Pete Stark from California. He was the chairman of the House Ways and Means Committee. Next slide, please. And Dr. Wallace, in his testimony, pledges that the ACR would take a leadership role in defining the most cost-effective and beneficial ways of utilizing radiologic services, and that pledged that we stood ready to design a system of patient guidelines to eliminate inappropriate utilization of imaging services. And if you take a step back and you think about the magnitude of the task that he was committing us to do, to take basically every imaging modality, every imaging study, every clinical condition, and put those into a framework to best define how that clinical pathway should go forward. It was a monumental undertaking. So what the ACR did was Later in 1993, going into 1994, next slide, please, the ACR created a task force, and it was actually chaired by Philip Cascade from the University of Michigan. And off we went. I mean, this was a sizable effort. Next slide, please. And the process was relatively unseen in the rest of medicine. And it was the guidelines to create these criteria were based on those from the AHRQ, which were themselves designed by the Institute of Medicine, which has since been renamed the Academy of Medicine. And how those criteria of appropriate use were defined were a combination of evidence when it existed, if not expert consensus. And along the way, there was input from physicians from other medical specialties, not just within radiology, but outside of radiology as well. So this process starts, and this is early to mid 90s. So let's fast forward. Next slide, please. Well, the focus on imaging continued, and this is an article you'll see policymakers reference fairly regularly, and that was showing the growth of different classes of services, if you will, within the Medicare population. And the optics aren't great, as imaging is sort of at the top of that curve as being the highest cumulative annual year-to-year change. To be frank, and to put it just to be direct, we were very much viewed in the crosshairs at this time. And that same spirit that went into healthcare reform 25 years ago, trying to be part of the solution, was something that I think from a strategic and I think logical and I think responsible perspective was something that the ACR considered. And to make things even more apparent, next slide, please, and many of us in this call probably lived through these, I know I did, was we were subject between 2006 and 2013 to at least 12 different payment reductions over 6 years. So if there was a perception that our services were overpaid and that our contributions to budget were too high, there were actions purposely being taken. Now, to be fair, much of this was a technical component, but not all. I mean, the MPPR for the professional component, but the effects on our specialty and the effects on our radiologists and our providers and even our patients was very real. So the spirit of finding a solution did not wane. Next slide, please. And if I haven't already made this point, I'm going to make it now. So when 2010, when President Obama signed into law the Affordable Care Act, which at the time was the most sizable piece of legislation and significant legislation in the healthcare space, probably since Medicare was founded in the 60s. The only specialty in the House of Medicine that contributed to this program was radiology. It was about a $3 billion hit in adjustment to our utilization assumption, largely to pay for the Medicaid expansion. So now that we're in more modern times, now we're in the 2010 timeframe, something needed to be pondered, some solution needed to be crafted. Next slide. Well, I've already shown you that what Philip Cascade started with the task force back at the time was now about 25 years old. We had hundreds of clinical experts actively working on a multi-specialty basis with a rigorous evidence requirement, with continuously updated, fully transparent, widely referenced guidelines. But they weren't particularly widely used at the point of care for a couple of reasons. One, it was on our website. It was available to anyone that was willing to or interested in downloading. It was available certainly in a PDF format, in a file format, but it wasn't being applied at the point of care to the degree that maybe would be possible. So next slide, please. So the ACR entered a partnership, and the partnership was with the National Decision Support Company to digitize those appropriate use criteria, to put those into a format that would allow information integration, workflow integration, digital capture for potential registry reporting, end-user feedback, and compliance. We created a product. We had a product available to take that 25 years of experience and potentially bring it for the betterment of patient care at the forefront. Then something happens. Next slide, please. So when PAMA passed, which is the Protecting Access to Medicare Act of 2014, when that passed in late March of 2014, policymakers were aware that the AUC criteria were a potential solution to ensure appropriate imaging and control expenditures and control utilization. We had made that commitment to the Ways and Means Committee 25 years prior, so this was no secret. So when that legislation passed, and by the way, that legislation passed, it passed in about 27 seconds if you can find the video and watch, but the vote was 60-35 in the Senate. There was no opposition from other medical specialties, and importantly, it kept radiology business management and organizations out of the process. And that had been in prior budgets. In fact, that was in President Obama's 2010 budget, was an RBM program for the totality of Medicare. And we know from experience from other specialties, and we know even feedback from the AMA, that the prior authorization process is not necessarily viewed favorably by the rest of medicine. This was, again, our chance to bring forth a solution to healthcare, to patient care, and that's frankly what we did and what we had done historically. So now that said, it is a law, it is a statute. Okay, this is a law that CMS is mandated by Congress to implement. So let's go and let's look at the original statutory timeline. And these are my last couple of slides. So the original timeline, and we've talked about this on prior webinars, the actual consultation requirement based on that original statute was January 1st, 2017. Well, obviously, we didn't collectively meet that deadline. The program has been subsequently delayed by regulations. And I'll go to the next slide, if I may, please, which is the existing or current timeline as we speak. And I know that Linda and Mike are going to talk about this as well during their comments, how the timeline affects our action. So let's kind of revisit this for a moment. So we are currently kind of between those first two green dots. We're kind of at the early part of 2019. So anyone who's using CDS within their communities, within their practices, can append a QQ modifier to their claims. Starting January 1st, 2020, so roughly 9-10 months from now, the educational and operations testing period begins. And then 2021 is the true start date, payment is at risk, and then there's an outlier aspect, which we'll talk about shortly, which will go into effect in 2023. But I want to close, and I want to make a few comments about this educational and operations testing period we're about to enter. Next slide, please. We are not the first program, or this is not the first program to be subjected to this type of a testing period. If you look even at the more recent measures, and I probably should have mentioned, so when PAMA was passed in 2014, that was the last SGR fix. When MACRA, the Medicare Access Chip Reauthorization Act, passed in March of 2015, that was the SGR fix. That replaced the SGR formula. And part of that was some cost episodes, which are beyond the scope of this lecture, but there were some episode-based cost measures which were recently field tested and rolled out. Well, those were subjected to an operations testing period. Those of us on this call in the billing space remember when ICD-10 came into effect, there was a testing and operations period. And then anyone that works in the pathology space knows the clinical laboratory fee schedule was subjected to just that. So this is not the first time that a innovative program within the Medicare program has been subject to this. And while we should acknowledge that this is work, that this is effort, that this is something that could be argued as a burden for practices to put into place, that this education and operations testing period is our chance, it's our opportunity to take something that Congress is telling CMS they are mandated to do and to gain from experience, provide the feedback to implement change and to make sure that the program advances and is put into place in the best way possible for the betterment of radiology professionals and their patients. So with that, Sean, I will close and I will turn it back over to you to introduce the next speaker. And I appreciate this opportunity. Thank you.
Great, Dr. Silva, thank you. Now I would like to introduce our next presenter, RBMA Federal Affairs Committee Chair, Linda Wilgus.
Good evening. It's great to be with you tonight. The topic of my discussion is a presentation is implementing clinical decision support in your practice. Next slide. So again, this part of the program is to start a conversation of what practice managers can do now to prepare for clinical decision support come January 1, 2020. We hope that this is a two-way discussion, so we welcome any and all inputs, insights that you can share. As you guys know, RBMA's mantra is progress through sharing. However, before we get into the meat of the subject matter of what practice managers should do, if you'll allow me to get back to basics on where we stand with AUC and CDS, and I'll apologize if my next few slides are a bit elementary, but I think it's important that we level set an understanding so that we're all starting from the same page. Next slide, please. So as a segue to Dr. Silva's updated timeline, there's no more kicking the can down the road. After years of discussing appropriate use criteria, clinical decision support, radiology utilization or overutilization, we now have a definitive start date. So if you'll allow me, I'm going to read directly from the MedLearn Matters fact sheet that was distributed in December of 2018. And it says, beginning in 2020, if you order Medicare Part B, Advanced Diagnostic Imaging Services, you must consult appropriate use criteria through a qualified clinical decision support mechanism. You must also provide that information to the furnishing professionals and facilities because they must report that consultation information on their Medicare claims. Next slide, please. So then what? Now, before I get into the meat of this slide, I do want to say that we anticipate getting additional guidance from CMS mid to late summer. And I also want to emphasize that all radiology providers, all components, the professional, the technical, or global, will need to submit the AUC consultation code on our electronic claims to CMS. So the 3 bullet points on the slide is that information that we need to submit. The ordering professional's NPI, what clinical decision support mechanism was consulted, which today in the rule, it says that they're going to provide us with G codes on what clinical decision support was consulted, and then a modifier that would indicate it was either appropriate, not appropriate, or not applicable. So as a practice manager, we need to understand and intimately know our data, how we ingest billing information and charge information from our referring physicians and our hospital partners, where they plan on putting this information to give to us in the transfer of that information, and how we're going to grab it and connect it to the exam that's being billed and submitted to our Medicare carriers. So Michael's presentation, which is next, gives you more detail and insight into the integration and interfaces of data, and also the possible challenges associated with that. But as a reminder, 2020 is considered an educational testing year. So payment for services by the rendering provider are not going to be impacted. But as stated in the previous slide, the rule states we must consult AUC. And as you know, this is a very complex, intricate process, and we need to get started on it as soon as possible in order to avert payment penalties that might occur in 2021. Next slide, please. So once again, back to the basics. What is appropriate use criteria? What is a clinical decision support mechanism? Well, I encourage you to hit the ACR's website. They have a lot of good information about clinical decision support, how it came to be, the definitions around the jargon. And I couldn't say it any better, so I'll let you visit their website to understand the definitions of those 2 terms. Next slide, please. Now, you might ask, how do I find out what is a clinical decision support mechanism? So this slide actually is directly from the CMS website as of last week. At the bottom of the slide, I actually have the reference or the site that this information was gathered, and I encourage you to visit that site routinely to see how the clinical decision support mechanisms have changed and if there's been more that's been added. Now, Bob Cook with NDCSC, and who's moderating our Q&A session, will probably be able to speak to this slide a lot better than I will. But what I hope that this slide communicates to you is that we need to be starting to talk today to our hospital vendors, to our billing vendors, to make sure that someone is having a conversation with these approved clinical decision support mechanisms. And again, I'll defer to Bob maybe later on in the presentation, but I also believe that in order to be a qualified CDSM, you also have to have a free tool for those providers that will not have an interface, an automatic interface with one of the CDSMs, that their users can actually go on a free tool in order to obtain an AUC answer. Next slide, please. So who's required to consult the clinical decision support mechanism? And this too comes straight out of the MedLearn Matters December bulletin. So of course the ordering professional, but the ordering professional can delegate it to a clinical staff acting under their direction. So, there's been a lot of dialogue around this component of the rule, and everyone's trying to be sensitive to the current practice patterns and burdens of our ordering physicians. We know that they have staff members who schedule the exam to attain pre-authorizations today. So again, we wanted to make sure that AUC and clinical decision support wasn't significantly burdensome to them. But I do want to stop here, though, and make sure that I draw a distinction between AUC and prior authorization. This program is not intended to be a prior authorization model. By design, this program is intended to be an educational tool for physicians and patients It's done at the point of care. So when the exam is actually ordered, that's when you should be consulting with an AUC clinical decision support mechanism. And it should be less of a burden than getting a prior authorization. You know your referring providers sit on the phone, their staff sits on the phone with utilization nurses, they're on hold. And so this is actually much quicker and more timely. And then lastly, it's not a hard stop to performing the exam. If you get a non-authorization from a commercial carrier, you can't do the exam without having the patient take financial responsibility. The distinction that I want to draw here is that even though if this exam is considered not appropriate, the patient can still be scanned and the rendering provider can still get paid as long as AUC was consulted. Next slide, please. So like all rules, there are exceptions. You can see on this slide, there's actually 3 current exceptions that the rule states. One is emergent services. And I want to make sure, again, I draw a distinction here. It doesn't say emergency departments, but emergency services that present themselves in the ER department. So Michael's going to expand on this a little bit more later in his presentation. So I'll pause there and I'll move on to the next bullet points. So inpatient services are an exception, as well as hardship circumstances. So the examples are insufficient internet access, if you are having some technical difficulties with your EMR, or the clinical decision support mechanism is having technical difficulties, and if there's extreme or uncontrollable circumstances. So again, as I've previously mentioned, we are still waiting on guidance from CMS on a lot of different components of this rule, and one of them is exactly how do we report that a referring provider was having a hardship? What does that look like? And so we're waiting for additional guidance there. Additionally, Michael's going to address another concern with critical access hospitals and how they have an exemption, but the radiologist may not. He'll be touching on that a little bit later in his presentation. Next slide, please. So what does this mean to practice administrators? So I really can't emphasize this enough. We have to start now. We have to start our discussions with our referring providers, start the discussion with our hospital leadership and their clinical IT departments, and we have to start the discussion with our billing vendors about processing the clinical decision support information. Next slide, please. So, are your referring physicians ready? We really don't know until we start the process and start the conversation. I can tell you, in my experience, in my market, I find the majority of the physicians are not ready. Those that are active in their professional associations or the AMA may be aware, and then some may have read a journal article and for the most part know if something's coming, knows the jargon, but many I find clearly don't know what that means to them. So we need to go about an educating of our referring providers. And I also want to pause here and capitalize on something that Dr. Silva said in his presentation. As we start educating our referring providers, I'm quite sure we're going to get some grumblings from them about this program. But as Dr. Silva mentioned, we need to remind them that this program was a part of the justification to eliminate the SGR. And all physicians, all subspecialties were faced with cuts to reimbursement through the SGR year after year. Next slide, please. So what should we do? These are a few recommended steps that the RBMA is actually pushing out to their practice administrators. Run a report, find out who your top referring physicians are, meet with your referring physicians and their administrative teams, kind of gauge a level of their understanding and their readiness to implement the policy. Find out what their EMR is. Chances are many are on a common EMR platform, and you can coalesce referring physician groups to start working on implementing this. Provide them a copy of that MedLearn Matters fact sheet from December of 2018. It's available in a PDF. You could be emailing it to your to the other administrators of your referring physician groups just to raise awareness. Really important, let them know that you are a resource for them as they discuss implementation and workflows. Volunteer to be a part of their team. Continue to monitor the ACR website, RBMA website, and CMS and the listservs that are associated with them. And as more guidance is issued and we learn more information, push what you learn out to your referring physicians and their administrators. Stay tuned, but don't wait. But currently the ACR and RBMA are in the process of creating a toolkit that administrators can use when having these discussions with their referring providers and their hospital leadership. And then check back in with the providers on a continual basis. I say repeat steps 1 through 7 all throughout the year to make sure that the process hasn't stalled and we remain engaged. Next slide, please. And it goes without saying, we need to do those exact same steps with our hospital partners and our billing vendors. Next slide. And my final thought here is, as I've said, we're waiting on guidance from CMS on some significant components of the rule. These has actually come from a letter that the AHRA wrote to the CMS. So just some of the guidance that we're waiting on is what are the actual G codes that are going to be used in the modifiers? And there could be the possibility, as you saw on Dr. Silva's slide, during this voluntary reporting period, providers that are doing consulting clinical decision support are using a QQ modifier. So if there isn't enough time to ramp up with the G codes, perhaps CMS will allow the continuation of that QQ modifier. As I previously said, more clarification about what is considered an emergency medical condition. I understand that hospitals, when they send their bill to CMS, they do not include the ordering NPI number on their claim form. So we're waiting for more guidance on where hospitals and those facilities will be putting that information. And then what do we do when Medicare is a secondary payer? Is AUC required? So that's, and there's other societies that have also submitted questions to CMS, and we're all going to wait patiently for the additional guidance. But RBMA's advice is not to wait for CMS to answer these questions, but to start now. We know these workflows and interfaces are complicated and they take time to change. And the more we accomplish now, today, and engage our partners in this process, the greater success we'll have in 2021 when reimbursement might be affected. Sean, I'll turn it back to you.
Great, Ms. Wilkes, thank you. Now it's time to introduce our final presenter for the night, IHE International Radiology Planning Committee Co-Chair, Mr. Mike Bull.
Thank you, Sean. Thanks, Linda, Zeke. Welcome, everyone, to this webinar. It's really important and that we all understand this. My name is Mike Bull. I am, as Sean said, I'm the IHE Radiology Planning Committee Co-Chair. I'm also the COO of the Radiology Group in Davenport, Iowa. Unlike what my photograph said on the introductory slide, I'm not an MD. I will say that I've been involved with clinical decision support since a cold winter night at RSNA in 2008, when a group of people got together to discuss CDS and sort of strategize on how to promote and advocate for it, and I've been extremely involved ever since. Hey, I'm going to speak with you tonight about implementing clinical decision support in a hospital-based practice. The lessons really are applicable to all settings, but I think the hospital practices have some unique challenges, which you will understand. CDS is one of the biggest changes to Medicare in our career, certainly my career. The scale of what must happen and the time frame within which these changes must be made is really nearly unprecedented. It's important to keep in mind the ultimate goal is to enable our referring physicians to order and our patients to receive the most appropriate test at the right time. Sometimes it seems complex, and yes, some of it is, but this is absolutely doable. We just have to break down the project to its core tasks and address them one by one. Having said this, one of the biggest challenges, I think, to a successful implementation from the radiologist's perspective is the hospital-based nature for much of what we do. We don't control a lot of the systems within a hospital, and that presents its own sort of unique challenges. Some health systems are clearly on top of this and have a very good grasp of CDS and its requirements. Others, however, while aware, are still working to understand what they need to do to fully implement it. It's absolutely imperative that we as radiologists are engaged with our hospitals and our health system as they work through this program. So today I'm going to relate a framework for how we can implement CDS in our practices and interact with CDS on a daily basis to help ensure that it's implemented as well as possible. I've got a lot of ground to cover, so I'm going to move quickly. Next slide, please. So, slide's blank. For all of us at one time, this is where we were on our journey to implementing CDS, a blank slate. I suspect there's a few on this call that are more or less still here. Next slide, please. However, wherever we are today, at the very beginning, hardly started to well on your way, this represents where we need to be. Note that there are both internal and external processes that we need to think through. Internal and external users, intake of the information, both an electronic and a manual receipt of the CDS information from the referring offices. It will involve the scheduling department, the ED. There's a real potential, and I'll explain why, to have CDS have to be used on some hospital floors, even though inpatients are excluded. I'll talk a little bit more about that later. There are other patients that will be on floors that won't be excluded. And then we get to the billing needs of the radiologists and the other physicians who also interpret CDS covered services. This does extend outside radiology, cardiology, for example. Again, at the end of the day, this is all very doable, but we really need to think about this and approach it in a very organized way. Next slide, please. So this is how I'm going to encourage you to think about it. The first step, engage with our facilities. Don't sit on the sidelines. Few people, and I would venture to say no one in a hospital setting, has a complete picture of the process. The truth is, we all work in our silos. And my sense is that while many hospitals are focused and moving forward, some are moving more slowly than others, or don't quite grasp the implications of what's being asked of them. So they need our input. And we need to make sure they address our needs as well, particularly from a billing perspective. For those of you who know what the red-green show is, as Red Green likes to say, we're all in this together. Next slide, please. So I encourage you to think in terms of a project plan. If the hospital has a project team, join it. Radiologist and their administrator, manager, be on the team. If they don't have a team, a project team, advocate for forming one. This will provide an organized framework for evaluating the current and future states of the project and for planning key tasks that you identify. Call it what you want, but develop a plan. The plan should assess and then address these four overall elements. Basic institutional readiness, the status of the installation and implementation of the CDS mechanism within your organization, and the planning and education and training of both internal and external users, external referring physicians, and of course, the billing needs of both the hospital and the radiology group. Many of your facilities may have already started, but frankly, few are fully implemented and virtually none have addressed the billing needs, largely because we were still waiting on some of the required information. Next slide, please. Here's an example of how you could sort of structure a project. It helps if you have a framework. This is an example of a basic project plan, from installation through limited rollout to full deployment, through training and education and claims filing. If you do something like this within each step, you should individually identify the needs for that step, assign appropriate resources, identify and involve the key institutional people by task, and then establish reasonable deadlines so you can move the project along. Again, this is a very doable project, and an organized approach will make it easier. Whatever you want to call it, whatever format it takes, get involved and get it organized. I want to take just a moment and emphasize one part of this, and that's the training. Don't shortchange the training. You're going to need to train your schedulers, train the radiology staff, train the nurses, train the ED staff, train your referring physicians, train their office staff, train everyone who will have a role in this. And don't just focus on your internal customers. Include your external customers as well. And particularly what I'm referring to is your external referring physicians who order a lot of outpatient imaging. Reach out to them and engage them as well. They will appreciate the help. And I'll guarantee you that in some of your markets, you're going to have aggressive competitors that are reaching out to your referring physicians and offering to help them in any way they need. Hospitals need to be doing the same thing. Next slide. And of course, then you need to implement the plan. Step 3. Next slide. Now I'm going to discuss the issue as probably the biggest challenge and perhaps of the most interest to radiologists, the mandate to place the CDS information on our claims, which if it's not present in the post-testing period, will result in the claim being denied. This is complex for many reasons, beginning with every hospital in the country will need to rewrite its export, and every radiologist billing system, radiology office, billing office will need to rewrite its data import. These queries, whether the export or the import, are often ad hoc, locally built. Radiology billing systems will need to rewrite their software and do so certainly at some point in 2020. This is happening and we can't control everything, but we absolutely need to focus on what we can control. Our facilities need to rewrite their data export. Our need to rewrite our data import to include the new information, and working with our billing systems to accommodate the consult information that we are required to put on the claim. Next slide, please. Here's a detail that probably most radiologists have rarely seen. I'm going to spend a few moments describing how most of us, get our data from which we then bill. Typically, our facilities, the hospitals will send the radiology group an export file each day. Maybe they get a single large file. Others may get individual files when the radiologist finalizes the report. This is a typical data export file for a single study. It's based on HL7 and it contains everything that we need to build our charge. It has patient information, it has the text of the report, it has the diagnosis codes, it has the history the radiologist dictates. Note the OBX segments along the left side from OBX1 through OBX35. These represent discrete defined data elements in HL7. The reason that's important, next slide, IHE and the HL7 work group have been working since late 2014, when PAMA was passed, on updating the underlying technical standards to incorporate the required CDS information into this format. with this last final rule, we were finally able to put the finishing touches on where the required information will live. For example, I've sort of collapsed the report, there behind the box. For example, the adherence modifier is going to be placed in OBX segment 8.1, and the text of the outcome, adhere, did not adhere, etc., is going to be assigned to HL7 OBX segment 8.2. The mechanism G code, if it's provided, will be in OBX section 15.1 with the mechanism's name assigned to section 15.2. Although not required by PAMA, we also created placeholders for some other material, other information we felt very important to have if it's made available, such as the decision support number. That will live in OBX 21.1. So you get the idea. These technical standards, basically are in place today. This is where they're going to live. And so what we're going to need to do is go back to our facilities and have them incorporate these data elements when they're in place into the export that we get each day from them. It's fairly simple, but it has to be done at every facility, which is where it gets sort of critical. Next slide, please. This diagram is meant to convey the extent of the relationships between the various actors, from the EMR, who typically has a fairly robust relationship with the hospital's IT department. The radiologists have a fairly robust relationship with their billing office or billing company, who has a relationship with the radiologist billing software system. However, focus on that red circle. Radiologists, while they have extensive relationships with the billing office, we really don't have, because we really don't need to, have very extensive or deep relationships with our IT department. Neither does our billing office or billing company. There's no practical need for that on most days. However, we need to make sure that your IT department is aware of our needs, and so you really need to work on those relationships, identify the key people in your IT department, and probably both the billing company and the radiologists will need to kind of collectively get together and approach the IT department and start to work on getting the exports changed. If we don't remind them, it's unlikely to happen. They're unlikely to be thinking about rejiggering our exports on their own. It's not necessarily difficult, but we need to have conversations sooner rather than later. Next slide. I'm going to mention a few unique challenges for you to keep in mind as we go down this path. Linda mentioned the emergency services exception, and it is an exception. Emergency services require a consult unless, next slide, the patient condition meets the definition, and this is in the in the regulations, unless it meets the definition of an emergency medical condition as defined in section 1867. This is 1867 in its entirety. I'm not going to read it. The point is that every emergency study, every study ordered in the emergency room is required to have a consult unless the patient meets this seemingly sort of narrow description of what's an emergency. I think seemingly narrow, I think it's a little broader than, it's going to be applied a little broader than what some might read into this. But those that meet the definition will need to be specifically identified so that when it is an emergency, we're going to need to be told it's an emergency because we need to put a modifier on that procedure. If it's not an emergency, we're going to need the G code and the outcome. Just a word of caution. This probably means that someone somewhere is going to need to make this determination almost on a case-by-case basis. Do I perform a CDS consult or not? If not, how do we tell the system that it was an emergency services and I need to assign a modifier to it? A facility may be tempted to set up all studies as qualifying as an emergency and then hope to remember to change the status when someone deems that it's really a non-emergent study. I don't personally recommend this practice. I think it will present some real compliance challenges. In my opinion, it's highly unlikely that all studies ordered in an emergency room is going to meet this definition. And trying to remember to change it when it doesn't will result in some studies that weren't emergencies being submitted as if they were. I won't belabor the point other than to say this is something that each facility is going to have to think through and sort of determine for themselves. And it's not necessarily going to be easy. Next slide. Next, I'm going to very briefly address, just as a word of caution, some unusual radiologist billing arrangements that are out there. I know of one smaller group who has their local orthopedic office doing all of their billing. It works, and that's okay. My only caution would be if you're using a service that does not specialize in radiology billing, please work with them very closely. They may not be quite as attuned to the requirements of our billing needs for this program as those billing companies who focus on radiology. I want to mention a little bit about observation patients. We see them with some frequency. Go to the emergency room, they put them on a floor and they're observation patients. The challenge is that observation patients are typically in a hospital bed on the floor, but they're considered outpatients. So it's very likely that physicians and floor staff are going to have to recognize when an observation patient has a study ordered that needs a CDS consult and then perform the consult. Challenge will be, these are going to be floor staff. They're not used to doing this. They're used to dealing with inpatients who don't need it. When you work through your project plan, just keep that in mind and make sure the floor staff are trained appropriately. Last is the critical access hospital exemption. They're exempted because they are paid under a different payment process. They do not have to include CDS consult information on their claims. However, at the present time, and we've read this over and over again, the rules can be interpreted that while CAHs are exempted from having to include the consult information on their claims, the referring physician ordering the exams and the radiologists interpreting the study could still be very well required to perform and to report the consult. In my experience, monitoring several professional society forums, many critical access hospitals are generally doing little to nothing about CDS because of their exemption. This would create obvious issues if radiologists must report CDS outcomes, not the least of which is how are we going to get the information from the hospital, who's going to provide it to us. We are seeking clarification from CMS on this issue, so stay tuned. I want to very briefly mention this. Critical access hospitals have two methods of billing. They're called Method 1, Method 2. Under Method 1, hospital bills separately, the radiologist bills separately. Under Method 2, there is an option. I called it Option A. Basically, the radiologist can reassign their claims to the hospital. And then the hospital bills and collects under option B, which frankly is what I'm familiar with, the radiologists still bill separately. I'm concerned about method 1 and method 2, option B, where the radiologists are submitting claims to Medicare Part B, even though they're done at a critical access hospital. Again, stay tuned. A lot more will come. A lot more information will come on this topic. But just keep that in the back of your mind if you are serving critical access hospitals. Next slide, please. I'm sorry, I forgot to say next slide. That's what I was talking about. Method 1, method 2. So technical efforts to date. This will be my last couple of slides. IHE Radiology developed the technical framework for the capture and sharing of this information. Immediately upon PAMA's passage, we began working on the technical framework for capturing this. It's called the CDS OAT profile. And HL7 began working to establish the HL7 fields I discussed earlier. The easiest way to describe how these two complement one another, HL7 is like the language. It determines the language, and IHE establishes the framework for how the disparate systems communicate using this language. With the publication of the 2019 final rule, IHE, as I speak, is putting the final touches on the interoperability standards, the CDS OAT profile. It is now ready for final ballot, and once that happens, the supplement will be published likely in May. Oh, by the way, for those of you who are unfamiliar with IHE, we develop a lot of the profiles that are used throughout radiology. The work's free, it's all open source. In fact, the people that do the work are technical engineers from all of the systems that need to speak with one another. We get into a room, in essence, take off the corporate hats and sit down and figure out how to solve these problems. This is what we did with this. And so there's no charge. IHE's works free for everybody. But our systems can now pick it up. Next slide, please. So system development efforts to date have been how to capture the AUC consult produced by the CSM. Think mostly the facility EMRs. It's based on IHE's and HL7's frameworks. Our billing software companies are really only recently able to even begin thinking about redesigning their systems. So we must work to integrate, our systems, the radiology billing systems, to accept the information from the EMRs. I strongly encourage each of you to contact your EMR and your billing software vendor and ask them these two questions. Do you plan to test the CDS OAT profile and upcoming IHE Connectathon? Basically, it's a big room that all the vendors get in and they just communicate to one another and test the communication streams. Are they going to test? And do you plan to support the profile when it's in final form? And if so, when? While I can give you no guarantees of success, I can absolutely assure you that those systems that implement the CDS OAT and test this profile will be highly likely to be prepared to deal with the claims billing requirement coming up here next year and beyond. So with that, next slide. That concludes my slides, and I'm now going to turn it back over to Sean. Thank you very much.
Great. Thank you, Mr. Bull, Ms. Wilgus, and Dr. Silva. As a reminder, as you see here, you can find resources to help you, your practice, and referring physicians get ready for the coming mandate at acr.org/CDS. Also, please visit the RScan website, including updates about the new clinical decision support RScan registry, as well as the ACR Practice Management Quality Informatics Toolkit. Next slide. Now, before we move on to the question and answer session, Please answer the following 2 poll questions. You have 15 seconds to answer each of these. Great, thank you. Now with that, Bob Cook, Vice President of the National Decision Support Company, will join us to start the Q&A session. You can still submit questions through the questions panel on your control panel. Now, our first question is from William Way, and it is, what happens if the ED determines they need an exam that requires CDS, but they refuse to do the consult? For the 2020 filings, can we simply say no CDS was done on the claim? Also, what will ED docs have to do to substantiate the need for an emergent study that bypasses CDS authority? We'll throw this one out to Dr. Silva.
William, it's an important question, and I think it's sort of a two-part question. I think the first question is sort of what happens if the ordering professional doesn't do the clinical decision support consult, and the challenge or the downstream consequence of that is that the furnishing professional, the radiologist, doesn't receive that decision support number, at least that information, for them to process their claim. So the question becomes, if that occurs, what happens from a claims perspective? Well, the question, CMS has said that it's a testing period in 2020. So if an attempt is made at the claim and that attempt is not accurate from a claims perspective, then payment's not at risk. Now, if no attempt is made whatsoever, that's not exactly clear, and we have not yet received that specific guidance from CMS yet or not, whether that would be payment at risk or not. That's a differentiation we're pursuing. That's an answer we're trying to seek, and hopefully we'll provide that clarification later. Now, to the first part of the question, if I remember it right, it was regarding the clinical condition versus the clinical site of service. And we've sort of talked about that is the ED collectively as a place of service is not in and of itself exempt from the program, but specific clinical conditions may or may not be. And maybe I'll ask Bob Cook to kind of, since he's joined our panel now, to kind of chime in with some perspective on this question.
Thanks, Zeke. So the first issue is that in terms of it's not up to obviously radiology to make the determination as to whether or not the service is emergent or not, or requires a consultation or not. Your job is to both report the information that was provided to you by the ordering professional. So if the ordering professional deems that this is an emergent service and they want to submit that as an emergent service as an exclusion, ultimately that data could contribute and likely would contribute to their outlier calculation. The other piece of the puzzle is obviously this does give you an opportunity based upon the AUC and your understanding of their practice of medicine to kind of cry BS, if you will. But that being said, with respect to what is needed to report on the claim, clearly there will be an exclusion modifier to the CPT code. CMS is going to issue in the summertime what those modifiers look like, which would include not only adherence and applicability data, but also the detail with respect to how each one of these exclusions is submitted. That being said, if the ordering provider provides you with, garbage, then your job is to report that garbage. And that information will contribute to their outlier calculation and cause them to be subject to future prior authorization efforts.
Yeah, and Sean, real quick point to build on, because William's question is really important. And we talked about this in one of the earlier webinars, was if a hardship exemption is communicated, it is not the responsibility of the furnishing professional of us to confirm or validate that. It is sufficient for us to trust that information is accurate from a compliance perspective and indicate on that claim without risk. That's an important point, William. Thank you.
All right, great. We'll move on here quickly. And we'll let Bob Bob, this one may be for you. Are there any penalties for not participating in the education and testing period?
Here's what I know. From July 2018 until January 1st, 2020, we were in a voluntary operations and testing period. As of January 1st, 2020, we are entering a mandatory operational and testing period. During the voluntary period, there was a voluntary modifier that was submitted. We know from CMS's commentary during the 2020 period that payment will not be withheld for not providing accurate information on the claim with respect to the consultation. The recent publication from the Medline Learns, the CMS on the Medical Learning Network, would indicate that they contemplate something to be committed. I could speculate that that might be a mandatory modifier / attestation to know that CDS was consulted and that you're aware of the result. You just haven't established a mechanism to convey the information from order to furnish in a detailed way. But that remains to be seen as to whether or not, but we know that during the January 1st, 2020 payment will not be withheld. The real question is that what will be required as of January 1st, 2020 in terms of accuracy to ensure payment.
Great, thank you. This next one may be for Mike Bohl, or if anybody else wants to address it, they feel free to jump in. What is expected workflow for times when the exam order is changed at the time of scanning due to SME or policy or protocol standards? Is AUC down to that level or just a modality level?
This is Mike. I frankly, I just don't know. The guidance has not been that specific. I would expect that what should happen, kind of like pre-authorization, it should be resubmitted. Now, that's easier said than done, and I think that's one of the things, I know that's one of the things that we will be seeking clarification for from CMS in the next few months.
Yeah, I could, let me add, this is Bob, right. Let me add to that answer. One, the AUC that are published absolutely cover contrast and non-contrast in that, obviously for a specific condition / clinical indication, contrast may or may not be indicated, and certainly the AUC do indicate that, one. Two, there are certain times when a furnishing provider can change an order for Medicare. Adding or changing of contrast is one of those circumstances, as I understand it. There are a few other circumstances where the radiologist is allowed to change the order, but not many. So that being said, in the event that we deviate, we're going from, let's say, a CT to an MR with or without contrast, then clearly a new order will be needed. But if we're moving from a CT to a CT with or without contrast, a new order may not be needed and the furnishing provider may change the order. Under those circumstances, your obligation is to report the data that was captured at the time of the order. And so therefore, whatever the appropriateness of the original order, regardless of how you changed it, is all you need to report. Now, that being said, with some of our EHR implementations, we do have ordering providers who and organizations that do not specify contrast on the initial order, in which case then we have configured the AUC delivery to select the best possible case and make sure that we are recommending the most appropriate exam for that provider to give them the best possible adherence information, with the understanding that the radiology will apply the modifier for contrast down the line when they actually furnish the service. And in which case then, again, the obligation is to report the data that was provided by the ordering provider on the claim and furnish the service.
Great, thank you. Moving on to the next question from Sherry Patch. Is there yet a definition for the clinical personnel who have to enter the order or in the processes through CDS? Can it be a nurse, a technologist, or what have you? And that can be Bob or Dr. Silva.
Yeah, this is Zeke Silva. It's an important question. So there was a change between the proposed rule and the final rule for last year. We talked about this in one of the earlier webinars. Was the initial language in the proposed rule was fairly generic regarding the ability of staff to perform the service, and we commented that we thought that it needed to be someone from a staff perspective that had clinical experience or clinical perspective, clinical staff, if you will. And that's what actually came out of the final rule in the regulations, was that it couldn't just be a non-clinical person in the office. And I mean this respectfully, it couldn't just be the receptionist. It needed to be a LVN, an RN. It needed to be someone that was clinically engaged with the patients. And so that's the find out. How it fits into the exact categorization of staff from a CMS perspective, that's going to be part of the claims guidance, I assume, and that will be forthcoming. Bob, anything to add on that?
Yeah, the rule states that it's licensed clinical staff operating under the direct supervision of the ordering provider. So it's clearly not a high school student in India. That being said, I think there's likely some flexibility in terms of how you might interpret licensed clinical staff operating under the direct supervision of the ordering provider. However, the ordering provider themselves should be made aware of the result of the AUC consultation, particularly if the AUC consultation and the order they're requesting is a non-adherent order. So many organizations have implemented actually hard stop on red, so that if somebody besides your responsible party places the order, that staff can't continue to proceed with that order unless it's overridden by the actually assigned ordering provider. So in any circumstance, if the consult is delegated, it has to be to a licensed clinical staff, direct supervision, and a means to convey, not adhere at the time of the order in the event that the actual service doesn't adhere.
Great. We'll move on quickly to the next question because we have quite a few. This next one is for let's let Linda Wilgus. Are there fields for the code going to be put into the claim forms?
Well, again, we're waiting on additional guidance, particularly on what the claim form should look like. But I draw on how we're submitting G codes for macromits. And so there, if you can picture a paper HCSA 1500, which no one submits today, but you have your CPT code with the exam, and the next line down, you have your G code that you're submitting for macromits with an explanation attached to that. So again, we're waiting on additional guidance from CMS on what that would look like. But since there's already a model out there with macromits, I would imagine it's going to look similar to that. And then what I don't know, and maybe Bob knows this better, today the QQ modifier is attached to the actual CPT code. But in the future, when we're given the modifiers for adhere, not applicable, hardship, if that will actually be attached to the actual CPT code, or if it'll be attached to the G code that has the indication of what clinical decision support mechanism was used. But again, we're waiting on additional guidance for that.
Yeah, our understanding is it's the CPT plus modifier and the G code reported on the same line.
Fantastic. Okay, the next question is from Neil Pashley. Which CMS POS numbers are impacted by the 2020 testing period? Bob?
I'm not up to speed on my CMS POS codes, but I do know that it is hospital outpatient services, independent diagnostic testing facilities, ambulatory surgical centers, and emergency department. And so I think 22 or 21 is the outpatient department, but I don't know for sure the numbers. Well, I can't correlate. I'm at this point, I can't correlate those numbers to the locations that I enumerated.
Okay.
Yeah, this is definitely 11, 22, and 23. Linda, is that accurate, or are there others?
No, I guess my comment was going to be, I don't know that tying it to a POS code is the right thing to do. Again, emergency department has a POS code, but that's not exempted. It's an emergent condition. Critical access hospitals have the same POS codes as tertiary or quaternary hospitals, but they are accepted. So I don't know that you can rely on a POS code, as the driver of if an AUC needs to be consulted or not.
Okay, fantastic. We're moving on to the next question. This one is from Catherine Edwards. With PQRS, if a claim went without the PQRS code, you could not submit a subsequent claim with the code to get credit. Can the code be added on a later claim to get favorable payment? I'll throw this one up for grabs. Bob, Dr. Silva, Mike, or Linda, whichever one of you wants to take the lead on that.
Well, this is
summer
Mike.
of this year.
No, you cannot submit it later to get credit for. Now, there might be things you could do. You could refund the money and refile, perhaps, but you will not be able just to send in a separate claim a week later and say, well, apply this to, this test done 10 days ago, because there's no mechanism for doing that. So, and they will have already paid for the CPT code, from 10 days ago. So, no, you want to submit the mechanism code on the same claim that, for the procedure to which it applied. And we'll just have to kind of go from there. But my thinking is, if that were to happen, you end up refunding and refiling it and probably be okay. A lot of work, so get it right the first time.
Okay, we'll move on to the next one from Joanne MG. And this, I'm just going to read her question verbatim. We use a very large EMR vendor in RED. She says she's contacted them that they do not intend to interface the CDSM into their EMR. They will provide a field to enter the number received, but require that we use a third-party mechanism. Is there any requirement that they embed the CDSM into their EMR? Bob or Dr. Silva?
Yeah, Bob, why don't you take this?
There is no formal regulatory requirement for the inclusion of the mechanism within the EHR aside from market forces. I believe the EHR here in question is evident. We've reached out to them as well and gotten similar answers. I might add that we have been both promiscuous with respect to our integration with third-party ambulatory EMRs and even offered no-fee integrations to many of the larger footprint EHRs, and continue to offer a free tool onto the marketplace by which, obviously the access to that AUC could happen through the free tool and that number pasted into the EHR or the adherence information entered into the EHR. But unfortunately, there's no fundamental requirement. We would be happy to speak with any and all EMR vendors with respect to, providing an integration.
All right, we're going to move on. Like as I said, we've got a number of questions here. So this next one is from Tom Greason. In 2020, the educational and testing period, may imaging providers submit claims for ATIS ordered by physicians without consulting AUC via a CDSM?
So I'll jump in and provide an answer here. Again, we're in the mandatory period from January 1st, 2020, and the CMS has indicated that they expect that consultations will begin and that some reporting of data will occur. So even if the process to report the data and the consultation process aren't connected electronically, the consultation still needs to start to take place by the ordering provider.
Okay.
Obviously, the hammer there is the law.
Okay.
Now,
Go ahead. Sorry.
This is Mike, and what I'm going to add that this is a question that we will be absolutely trying to get an answer from CMS over the course of the next few months.
Okay, great. We'll move on to the next question. Oh, go ahead, Dr.
Real
Silva.
quick, Don, quick point. And I think the question, the relevant question here is if nothing's done. I mean, the claim is filed and there's no indication whatsoever that a clinical decision support mechanism is consulted, or if it was, there's no indication that data was transferred. What happens to that claim in 2020? Is that paid or not? And we've asked the question of CMS several times, and it's relevant because it affects sort of urgency of action, if you will, at the community level. So as soon as we know, and as soon as we have that kind of guidance, as Mike said, we will make sure that that is out in the public domain as soon as possible.
Okay, great. Going to move on to the next one from Mark Montgomery. This one's for Linda. Feel free to after Linda answers, if anybody else wants to jump in, but what type of input information will the referring provider need to provide when using CDS? Is this information different from current workflow? Do they specifically mention a sign or symptom and a ICD-10-DX code when ordering a study with CDS?
Well, Bob might be a little bit more qualified than I am to answer the question, but from the demonstrations of the platforms that I've seen, they actually enter a reason for the exam, which can translate to an ICD-10 code, and then the exam that they're being ordered. But Bob, I know you've you live, eat, and breathe this, so I'll turn to you.
Yeah, that's correct, Linda. The AUC are driven based upon a clinical indication, i.e. the free text or that you would enter into the box next to the ICD-10 diagnostic code. In some cases, we're capable to map those indications to ICD codes. In other cases, we aren't. And so, but generally, the CDS is triggered off of that indication, the clinical question to answer, and what the appropriate procedure is opposite that clinical question. And I'd encourage the audience to hold on to that fact with respect to the difference between an indication and an ICD-10 as we work through the stack of questions.
Great. This next one, Bob, is for you. Will NDSC have a product that radiologists can use on their provider portal or website for ordering physicians who do not have an EHR?
Absolutely. We have already a free tool that is out there, and we'd be happy to speak with furnishing sites to make radiology sites to make that tool available. And like the ACR, we are developing a toolkit and a set of services to help enable these furnishing providers, the radiologists, to engage best with the program. So our free tool would be the tool that we would recommend the radiologists provide to their ordering physicians in lieu of integration with the order entry systems that may already be in use. We will not be building an order entry system.
Okay, great. This next question I would say is from Mike. It's from Vicky Parikh. I hope I'm pronouncing that name right. If an AUC code is not provided by the ordering physician, will there be any way for us to look it up? Similar to how we can find an insurance authorization number if we're unable to reach the ordering provider?
Well, it's going to be challenging, but that's one of the reasons that we want and strongly encourage groups, facilities to obtain the decision support number. And Bob can address how CareSelect works today. I'm not sure. I think eventually it will work better than perhaps what we can do today. Retrospectively checking something is going to be difficult, but we need that DSN number, and we've created placeholders for it. So Bob, you want to answer?
Yeah, the minimum piece of information that we'll need in any event, and I believe it's the best practice because what the DSN number does is it connects that encounter within the EHR, that actual consultation, to the furnished service in some traceable way for future program integrity purposes. But that being said, obviously, if we have that unique identifier, that decision support number, and we know it's from our mechanism, we will be able to provide a what I'll call a reverse lookup, for lack of a better description.
Okay, this next one is for Dr. Silva from Carol Freya. Will CDS replace the Medicare LCDs?
It's a good question. So when you think about sort of the two processes that go into claims, you sort of have the coverage determination where the diagnosis code and the procedure code need to match for medical necessity purposes, and if they don't, a claim could potentially be denied. That's kind of one claims processing pathway. And then the one we're describing tonight is sort of a parallel process where the appropriateness has to be based on the diagnosis and the study, and that needs to be documented. They're parallel. I mean, we'd like to think that we can take steps to make sure that they are complementary and congruent, but at the moment, those are separate parallel claims-based processes. But I don't know, maybe Bob or Mike, maybe you can chime in and maybe add some more perspective on that.
Well, this is what
I can add. Yeah, go ahead.
Go ahead, Bob. No, go ahead.
So I can add that we've asked CMS the specific question with respect to the role of LCDs and NCDs within the ACC program, and they both consider those LCD and NCD process to be active and binding during and detailing the criteria under which coverage is based. And consulting with AUC is not a replacement for determination of medical necessity. So obviously consulting with an AUC that may or may not conflict with an LCD doesn't modify the applicability of the LCD. And that's what CMS has indicated at this time. We do understand that there is a lot of questions about this, and we certainly would like to see these programs better aligned, but they aren't at this time.
Okay,
bear with me. Some comments?
No, I think
one of the things I would say, Yeah, I would say that one of the things is at the local level, to the extent that, if you're involved in the process of determining local coverage determination and even national coverage determination, clearly there's an opportunity to continue to force the issue from the other direction. And LCD and NCDs are typically based upon the ICD code versus a clinical indication, which also, contemplate the difference between, the way that the criteria is delivered and used within the workflow.
Okay, we'll move on to the next question from Sarah Reimer. If a healthcare system is changing EMRs during 2020, how or can they apply for a hardship exemption? Dr. Silva, Bob, either one of you.
The information that I have right now is that hardship exemptions are applied for in the same way that the meaningful use program exemptions are granted. It's not clear to me that will persist, and whether or not the process to exclude is based upon just simply an attestation by providing that modifier, or there is going to be an application process. I just don't know.
Yeah,
okay.
This is Jake. Yeah, it's a good question, and we should jot that down, Sean, and make sure we find the exact answer for that, because there are hardship exemptions for, as Bob said, meaningful use. There's hardship exemptions for the merit-based incentive payment system, and now we're talking about hardship exemptions for this program, and we need to make sure that the billing crowd knows exactly what's required for each of those. That's a great question. Thank you.
All right, great. And yeah, just as a reminder, we keep all of these questions, and we will be answering many of the questions that we did not get to on tonight's webinar over the next coming days and weeks. So be on the lookout for that, those of you who did submit questions. This one's a little unique. It's our first one here. This one is from Russell Tarver. As a physician's office, we occasionally provide imaging services for outside physicians. They add in parentheses, they are an oncology practice. We are responsible for providing, or who is responsible for providing the CDMS data when we submit to outside radiologies or radiologists for reads and the claim ticket, our physicians or the ordering physicians? Bob or Dr. Silva?
I'm just reading the question. Here we are.
It's a little involved.
I see. So essentially, you as the furnishing service would outsource the radiology service as part of your overall service, in which case then it might make sense for you to provide that data on the claim. If the provider organization or the physician provide imaging service oncology, boy, this is a complicated question. I think we're going to have to dig into that a little bit more.
Great. No, we will do that. As I said, that we are collecting these. Go ahead.
Yeah, I mean, I do think that at the point of ordering, I think that is the ordering professional, that consultation needs to occur. And then whoever's billing as the furnishing professional, whether that's the radiologists themselves that this entity is contract with, or the entity itself on their behalf, I mean, whoever's processing that claim, that CDSM number and that communication needs to occur. But I agree with Bob. It's a complicated question. It's another one for us to consider carefully.
Great. We'll do a couple more here. This one is from Saget Frazier. And their question is, it was submitted at 8:03 p.m. Do senior plans have to comply with AUC? I assume they're talking about supplemental to Medicare, but you would know better. Bob or Dr. Silva?
Actually, I think this is in Mike Bull's slides, perhaps, or Linda's, one or the other, to talk briefly about secondary payers. Is that?
Yeah, so when Medicare is a secondary payer, we're still waiting on guidance from CMS if AUC needs to be consulted there. What I'm wondering is the question is really asking if the Medicare Advantage plans need to comply. The managed care Medicare plans, I wonder if that's what is being asked there. Clearly, I don't think if it's a secondary AARP or a secondary commercial, I don't believe that those are required. And you would have done it with the primary being Medicare. But I'm wondering if the question is more asking if it's the Medicare Advantage plans. Everything that I have read, and again, I continue to look for more information about this, but I believe it would apply to the Medicare Advantage plans as well. And I'll turn it over to my other panel members if they have different information.
Okay, I'll tell you what, we'll move on. We're going to take two more questions here. And then, like I said, we are keeping track of these questions and we may answer via email many of these questions over the next days and weeks. This next one is from Thomas O'Neill, came in at 806. Can you elaborate on the outlier calculation and its implications for the ordering providers? Being able to explain this to referrers may help encourage a more enthusiastic adoption and participation from the ordering providers.
Yeah, this is Zeke Silva. It's an important question. So one of the mandates of the programs, remember, it's not a prior authorization program. This is a point of care clinical decision support program. But one of the mandates was the identification of outliers, which would be subjected themselves to prior authorization in subsequent years. And I showed one of my earlier slides. That was supposed to start, I think it was the 2020 timeframe. Now that's pushed back to 2023, 2024. And it's been clarified that that's based on some 8 priority clinical areas. So to the point of the question, it's completely relevant to point out that this is a program that if and when we participate favorably, that is a means to avoid prior authorization later into being identified as an outlier. So it's a great question. Anyone else? Bob, Mike, Linda, anyone else have anything to add on that?
The outlier calculation obviously is the important component of the program, in that obviously it's essentially radiology's tool to help, provide guidance to these ordering providers as to what the most appropriate exam actually is. But unfortunately, we do not know what the outlier calculation is. So we could use that information one of two different ways. One being, the opportunity to, continue to, reinforce and show that the program has merit, and we're creating impact through it. And the second opportunity, obviously, is ensuring that the consultation, because we don't know how CMS is going to be guiding and where these consultations need to take place. We do need to be conscious of the fact that we are exposing as many ordering providers to as many AUC as possible to ensure that they aren't outliers.
Okay, this is our last question of the night. It is from Deborah Shupenis. And they say Medicare Advantage plans already require authorization from a third party. Do providers have to do both the pre-authorization and a CDMS authorization? Dr. Silva, or go ahead, Linda, sorry.
Well, again, I kind of was addressing that particular question when I spoke the last time. And again, everything I've read, I haven't seen where Medicare Advantage plans have been excluded. So this may be an area where we need to have additional guidance, but I have not read where Medicare Advantage plans are excluded from this.
The only question I would ask is Medicare Advantage Part B. And I don't believe that Medicare Advantage B is Part B, and that's what the legislation and the statute applies to.
Yeah, and this came up in one of the earlier webinars. I want to say that was our conclusion, that because it's not part of Medicare Part B and it's sort of a separate private managed program, that it wasn't necessary. But recognizing that this question has come up a couple of times, I think we'll add this, sort of our high priority list to clarify and get that information out as soon as possible. So really appreciate the question. Thank you.
Great. Thanks, everybody. And again, we will make every effort to answer particularly those questions that were recurring, that were coming in over the next few days and weeks. Again, I want to thank Ms. Wilgos, Mr. Bowl, Mr. Cook, and Dr. Silva. And I want to thank all of you for attending tonight's webinar. You will receive a follow-up email with a link to a recording of tonight's webinar over the next couple of days. The recording will also be posted to acr.org and rbma.org. Again, thank you for joining us, and have a great night, everybody.
Thank you.